So that's why the importance of this field comes. Here we treat the child or the any adult amblyopia patient. We treat in the monocular fixation in binocular field. So
Yeah.
we never for the shut of one eye.
One
Like,
eye.
because we are like shutting that depth perception, we are shutting the fusion, we are shutting everything.
Everything. Yes.
Not correct. And that's why only you don't see any improvement because you are closing one eye. So the timing, the amblyopic eye will work. But the moment opening the good eye,
Yeah.
the good eye will fixation and charge because brain is very comfortable to work with that eye. Brain is not comfortable to work with the amblyopic eye. That's why that eye has become lazy eye.
Easy. Welcome to another epic episode on my YouTube channel. So today we are going to discuss about binocular vision as a specialty subject. Currently, what I feel is binocular vision is one of the most trending subject in the field of optometry. And for that, I'm inviting Miss Priti Mistry. She is an optometrist also specialized in the field of binocular vision. Currently, she practices at her own optometry clinic, which is named as Prime Eye Care. And in her practice, she not only managed patients with binocular vision disorders like NSBVD, but also she also managed patients with CPI and autism and other neuro-optometry disorders. So for the students who really want to know the current binocular vision practice, so you should definitely check this video. So without any further delay, let's get started. Welcome Priti ma'am to my channel and thank you so much for accepting my invitation.
Thanks, Monil, for inviting me. This is a really pleasure for me to be a part of your this channel, you can say, or the like what you're doing to create the awareness about all different professions. So it's an honor to be on this platform.
Okay. And as you mentioned that this is your first postcard, so how are you feeling right now? Like, can you share a little bit?
It's kind of mixed feeling. Like, I always wanted to share this journey, but I never thought that I'll share this way. So it's a mixed feeling. A bit nervous also because this is my first podcast, as you mentioned.
Yeah.
And I always wanted to, create the awareness about BV because this profession, feel right now, though maybe you can hear from people's mouth like VT, vision therapy, binocular vision. But when I started, no one was aware of it. So,
Correct.
like, hardly people knew about it. Anyways, right now, also, hardly people knew about it, like, about our profession, also, you can say.
Yeah.
So, they consider you as an optician or the ophthalmologist, like a doctor.
Yeah.
This is the like, between. So, and in that, again, the VT is like, so no one was like aware of a patient also to convince them about BV or VT was a task. So, like, it's a
mix.
I can say. I'm happy also, and I'm a bit nervous also.
Okay, so like as you mentioned that you are in the field of binocular vision, right? Since how many years you are practicing BV? Like
12 years.
12 years. That's a huge amount. 1 decade and 2 years. so like
Yes.
so like as per your experience, like what are the best thing of BV practice and what is the worst part of BV practice? Like maybe on the both the side.
So first I'll say good things.
Yeah.
Definitely. So the good things are basically it's very satisfactory profession, I can say. You feel end of the day very much satisfied that whatever you are doing for betterment of the patient, definitely, yes. But it's a job satisfaction, end of the day, definitely you'll get it. If you are passionate, the condition is that only if you are passionate. So that definitely this is a slow process. You won't see the change in a day or two. So slowly, but when the patient see the change, when patient starts observing the difference, and when they'll come and they'll give you that feedback, that will satisfy like whatever pain, whatever the time, whatever amount of energy you have given to this patient, that worth it. So that worth feeling you will get end of the session or maybe end of the treatment plan. And the smile, what you see on the kids, on the parents, it's amazing.
Amazing.
So, basically, yeah. and you are treating the patient. So here you are not treating only the patient, you are treating the brain. You're treating tiny children,
Yes.
So yeah, so good part is like it's always a job satisfactory. You are not doing like 9 to 5 ka typical that finishing the task, achieving the targets and all things. So it's something different than the routine, what you're doing. So that is the one thing. The second thing, as I mentioned, that you are treating the brain. So I would like to elaborate that thing.
Yeah.
Here, you have to see the psychology of the patient because as you know, the BV means binocular vision. So importance of binocular vision should be like, I feel everyone should know the importance of binocular vision because if there is a lacking, any part of this, basically we have a major 3 grades of binocular vision. That is a sign of simultaneous macular perception, we say. Second is a fusion, and third is a stereopsis, 3-dimensional vision. If these 3 grades are available or present in patient's eye, then they'll achieve like whole world in a different manner. But if any grade of this is absent, then patient is suffering a lot. And sometimes patient also don't realize that they are suffering. They just accept the world. Okay, my world is this way only. I can see this much, so this is for me, this is the normal vision. But when like treat that patient and when you show them the change, okay, not the correct way, what you have adopted, like abnormal head posture, abnormal viewing condition like squint and all. So this is not the correct thing to visualize. Or sometimes they have never experienced the 3-dimensional vision. For them, the 2D vision is the vision.
Vision. Yes.
So when you make them experience this and they see the difference, this change, like see the change, and that the feel like the basically you change the whole lifestyle of the patient.
Yes.
So and because of the wrong adaptation, patient have developed the wrong mindset. So you're the full mindset. So you're treating the patient psychologically also and ocularly, like binocularly also. So I feel that is a very good part of this binocular field, binocular vision field, basically.
Yes.
So that is the good part. Now we go to the opposite side.
Other side, yeah.
Yeah, other side of the coin, basically, like you can say. So definitely this is time consuming. So you get the result immediately. So you have to be patient. You have to tell the patients to be impatient, give time and all. So that is the first thing. So definitely your efforts, what you're putting will pay off slowly. You won't get it immediately.
Yeah.
You will earn quick money because nowadays that trend is going on. Everyone wants to earn quick money.
Money,
So
yeah.
that is not possible.
Yes.
Like, see in contact lens and all profession, or maybe while dispensing the spectacles or something, you earn quick money. Like you dispense, earning the money, right? So you take the order, you get the advance, then you dispense, then you done with the patient. Then you do the regular follow-ups, definitely, yes. But then too, you are done. So that is short-term like process. But this is definitely goes sometimes in the special needs children, this goes for years and years.
Yeah.
So because for them, like for in case of any CP patient or CVI patient, if I'm talking about, or maybe autistic child, then slowly you are developing all the different milestones of the eye.
Yes.
So then, yeah, you are starting from the fixation to tracking movements to the pursuit, second. So you are working on, and definitely that this child is not gonna achieve all the parameters of binocular vision. Yes. Somewhere something will be lacking, definitely.
Yes.
So definitely, so this is a very time-consuming process, as I mentioned. The second thing, if you think the big money, you cannot, because in this patient has to come for multiple settings.
Multiple settings, yes.
So you cannot charge like a bomb. It's a slow process. It takes sometimes months, sometimes years. So it's a very slow. So definitely you are giving more time, and in return you are getting, if you see financial wise, then you are not achieving that much back. what energy, what time, and what infrastructure you are putting into it.
Because it requires a huge investment also. I can
Yes.
see people sign up to a big side.
Yes. So
Yeah.
this is only one instrument. We have many. As
Yes.
you know, you have already visited. So
Yes. Yeah, it's actually
and
lovely.
basically in this you need to keep on updating yourself. So you need to update yourself. So you have to invest on yourself also, the
Education.
time and money. You
Yes.
have to yourself, you have to keep updating yourself. Simultaneously, you have to update yourself with the instruments also. As we all first we used to do this only manual VT.
Yeah.
Now we have also in that. So
Yeah.
many work softwares and everything is possible, like available nowadays. So if your knowledge is good, then you can definitely make out that which software is ideal for you or
Yeah.
which technology you should go for it, something like that way. So you need to keep updating yourself, educating yourself, and you updating your practice also.
Correct.
And the third point, which I'm feeling that is a drawback, that you don't get immediate referrals. So
Yes.
this process is based on the word of mouth only. So if the one patient is like improving in a 6 months time, then that patient will go develop the trust. Then they'll go out and then they'll share with the other parents or other people like colleagues and all. Okay, I have got this much improvement. I have improved. So now you can also try. You know, that's how the network will build.
Yes.
But referrals are very, very less, I can say, because in our profession, half of the time people are not yet believing that exercise will help.
Exactly. Yes.
So that is the main challenge what we faced.
Yes. And what I feel one more challenge is to convince the parents. Like whenever we counsel the parents that we need to do this exercise and he has to come multiple times. Like how do you manage the situation? Like because parents have so much of expectation that it should be cleared in 1 day or 2 day. So how do you manage
Yes.
that situation being an BV specialist?
So yeah, so basically, for parents' point of view, see nowadays, if many parents are very educated
Yes.
and they research and do come.
Yeah.
Okay. So sometimes somewhere Google is helping a lot. So in that case, definitely yes.
Yes. Yeah.
So they come with the research and reading and on and on.
All right.
So few parents like who are from the educated group, it's easy to explain them. They connect also because they have feed the brain. Already they have the brain with the information. So it's easy to explain them in a good terminology and they understand also and they are okay with that. They have come with that expectation only. Okay, it will take little time. They won't see the immediate change. But yeah, one group of parents who are not aware of this field only and it came from through. So they are not aware. They have seen first time this kind of setup. They don't know anything about exercises existing or something like that. To convert those patients into the VT like in vision therapy is a bit challenging. But definitely we try our best. We draw the diagrams. We explain them. Okay, this is your both eyes. This is the kind of we give many examples. Okay, this is the kind of binocular really works like both eyes coordination works. If you are lacking in any parameters on this path, then you may face this. Is your child is facing this way? So we made the questionnaire. We asked the question like questions. Is your child suffering from this? Have you noticed this? Have like teacher told you this? Like that way, and then they can correlate with the reality, and then they convince with this. So that is a little bit long journey to make them convince about the. But yeah, basically they also have seen the child is growing with some label, with some like condition. Yeah. So they have seen. So then they start correlating. So many examples, and you have to explain details basically. So
Okay.
that's what I'm. You are not dealing with the only eyes. You are dealing with the brains, different brains.
Yes.
So you understand the psychology of the parent. You have the psychology of the child, and then to plan everything.
Correct. And do you feel the role of ophthalmologist in this, patient referral and patient counseling, like pediatric ophthalmologist specifically, I wanted to ask. Like, how do you manage with them also? Like, do you have any, tie-ups with the hospitals and something?
Yeah. So the thing is that pediatric ophthalmology plays a major role in this.
Yes.
But yeah, as I said, many patients are not aware that pediatric ophthalmology is existing.
They
So
are
they go to
yeah.
ophthalmologist only, and they do their eye checkup and all and all.
Yeah.
And there they, so for example, in case of amblyopia, the simple thing I'm discussing right now, the first we can take it as an amblyopia. So what happens when the child is amblyopic? They'll say do the patching.
Simple.
They don't see the compliance of the child, whether they are doing the patching regularly or not. And you know what happens? Like in this my 12 years of journey, I have noticed that the patient parents are behind the child to do patching, patching, patching. Child is for a 1 month or 2 months sincerely, like 3 hours, 4 hours, whatever you have advised, sincerely. After that, child is also losing the interest. Because imagine by doing the patching, you are breaking the binocularity.
Yes.
You are the child in the worst condition, which you should not. Imagine if I'm only telling you to do the patching and roam around in the room, you will get tired in 30 minutes only. Exactly. Your mind will get tired, and child will go in the trauma.
Yes.
This is not the enjoyable condition for the child, or not for the brain also.
Yeah.
Correct. So the thing is that you should not advise the patching. First thing, you have to treat the child. There are other technology. Definitely, this is the olden technology, because we were not aware about any other technology. Yes. So we were for this traditional method. So that's why the importance of this field comes. Here we treat the child or the any adult amblyopia patient. We treat in the monocular fixation in binocular field. Yes. So we never for the shut of one eye. Because we are like shutting their depth perception, we are shutting their fusion, we are shutting everything.
Everything, yes.
Not correct. And that's why only you don't see any improvement, because you are closing one eye. So the timing, the amblyopic eye will work. But the moment opening the good eye, the good eye will fixation and charge, because brain is very comfortable to work with that eye. Brain is not comfortable to work with the amblyopic eye. That's why that eye has become lazy eye. Right? So in that case, you have to open this eye, like the good eye, and you simultaneously you have to allow the amblyopic eye to work in coordination with this eye. So we have that red blue glasses and all to fixate the both graph and all. So that's the thing basically. So pediatric ophthalmologist role is very important. They are quite understanding also key vision plays very vital role in development of the child physiology, anatomy, and the binocular vision.
Yes.
Okay? Not anatomy exactly, because that is a natural development, but definitely physiology of the eye.
Yes.
Binocular vision, definitely. So they do refer. Definitely they do refer. But there are a few practitioners who feel, okay, we'll do follow-ups, we'll do, and then the end
wait
we'll
and
see.
watch, usually.
Yeah, but I always say, if you see after 3 months or 4 months, if child is not improving, if the squint is not reducing, and the squint is not in a condition to operate also, for example, because it's in the stage of intermittent squint. So definitely in intermittent squint stage, we cannot operate. So in that case, you please refer those child or a patient, adult patient, to the any vision therapist, to improve their fusional versions, to improve their both eyes coordinations, to improve their depth perceptions, to improve their lazy eye vision. So you can definitely refer to those special areas, basically.
Yes. So like
but we do get pediatric ophthalmologists. Yeah.
So it's a win-win situation for both of the things, because they cannot operate in such scenario. Let's say amblyopia or some other condition.
Even sometimes after surgery also I have noticed that patient, due to the suppression of particular eye, right or left, whatever you can say. So due to suppression, after surgery also patient may tend to deviate again. The fixation is not maintained, so the eye slowly go into the deviated position. But due to surgery, it goes into the reverse position also. So for
Hmm.
example, if you have it for exo, you see little ESO
Easily.
deviation,
Yes.
or you slowly start seeing exo deviation also gradually. So in
Hmm.
that case, the VT plays very important role to stimulate the central fixation.
Yes.
So it's that way. So like post surgery also, VT plays very important. So this I have seen like when I was in Shroff Hospital.
Hmm.
So like as you know that in Shroff, we are the first one in Mumbai who
Yeah.
started vision therapy department in Shroff Hospital. So it's all because of the Dr. Ashok Trust that he was like in UK before independency of
Hmm.
ours, like 1947. They
74.
can say.
Yeah.
So he was in Moorfields, and there he has seen the orthoptics, importance of orthoptics, importance of binocular vision and all. So
Yeah.
he was very much keen to start something, but due to his like big practice and all, he was not. He got the synapto for that time from UK.
UK. Yeah. In
Yeah,
1950s around.
in
Yeah.
1943 or 44 something.
Okay. Before independence.
Yeah, before independence.
Yeah.
So he went for his masters and all in Moorfields.
Yeah.
Fellowship program and something.
Hmm.
And that time he got very influenced with the VT and binocular vision, and he got synapto for that time. And in Shroff, they had synapto for. And like when I was there working in Shroff, and first I did my internship on Shroff, and then I was working. And that time, this even I was very curious about VT and binocular vision and all. So they saw that thing and they were like, let's develop something. Because
Yeah.
of my practice, I couldn't devote that much time to my orthoptic patients or my BB patients because I have to give time for surgeries and OPDs and all. So he was like, let's start something. So we were the first one who started binocular vision department in Mumbai, basically.
Yeah.
Definitely it was available in Delhi, in Chennai, in Hyderabad, in Nemli Prasad, Shankara and all. But in Mumbai, we were the first one who started a binocular vision department in 2012.
2012. Yes.
Yeah.
Yeah.
So we like got all the instruments from US because that time in India, so instruments were not available. So we ordered everything from
UK.
US and
Yeah.
got it. Then that's how we started. So that time, so for like patient also, it was very new. ये
Exactly.
ये क्या
What?
हो रहा है?
Yeah.
ये कभी देखा ही नहीं था.
Yeah.
It's like that.
Yeah.
But it was a good journey.
Yeah, even I feel so, like shocked that in 1943, as you mentioned, to bring a synoptophobe, it's really so challenging and it's a good story actually. And talking
Yeah.
about Dr. Shroff, like you also did your fellowship from in binocular vision, right? To gain the,
Yeah.
special
That
knowledge.
yeah.
Yeah,
That I did it from Delhi.
Delhi.
Delhi doctor.
Yes, yes. Yeah. So how helpful was your fellowship? Does it play an important role for anyone who have to, jump into BB practice? Like, is there something you're like learning from the fellowship?
Yes, definitely. So, the thing is that after completing my BVP, like graduation,
Yeah.
so first I have done my diploma. So when
Yes.
I did diploma that time in Mumbai, only one degree college was started. And that was just started. Like I took the admission in diploma the same year, degree college was started.
Okay.
So it was a very new. So we were not aware about the how the college will run and how the course will recognize degree course and all. While in SNDT, the diploma course was running since many years.
Even
So it
yeah.
was a recognized course.
Yes.
So
Yeah.
that after 12th, I joined the diploma. Then I worked for a year. And
Yeah.
then I realized, no, I should go for a degree also. So that time, that 1 year, which degree college, which I was saying, that started in HHK, that Hitwardhan or something, I don't remember the name, the full name, but it was HHK.
Yeah.
So it was started in HHK and it shifted to Lotus. So we had only one degree college, which is Lotus,
Yeah.
like that. So I was confused between Lotus and BVP, but BVP again well recognized and it's from many years and all. So I was like, okay, okay. Anyways, I was getting the lateral entry, so I was getting the admission in third year. So I have to study 1 year only. Then again, the next year is an internship.
Internship.
So I can do the internship in Mumbai. That was the mindset. So only 1 year I have to go out of the Mumbai because sometimes you have restrictions from home also. Okay, you cannot travel so much. You cannot go like that way. So then somehow I convinced my parents and I went for a degree. So after working 1 year as an optometrist, clinical optometrist, I realized we should do degree definitely to enhance our basically education, you can say, or different skills, because you study in different fields in details, basically in depth. In degree diploma. So that's how I went. Then I did my BVP, B-Optom. I completed in 2008. Did fellowship in 2011.
Okay, after 3 years of
Yeah, again I was working, but in BVP, Dipti ma'am, Miss Dipti Gokte.
Okay.
Pramod sir's wife, basically.
Yeah.
So she was our orthoptic teacher. And she made us do some instruments. She was like, you all are studying, why you are not making the instrument?
Yeah.
So please make some instruments. So she gave us a list of instruments. We made a group and we celebrated Orthoptics Day. That way in the BV. And while making instrument, that somewhere clicked me. This is a really very renowned profession. I don't know why, but it's big in India. So that time Dipti ma'am used to do it little bit therapy in her optical store in the evening time.
Evening time, yeah.
She used to see few patients, so like few exercises, like convergence exercises, accommodative exercises, like that small part of VT, she used to do it in Pune.
Yeah.
That area clicked me. Then again, after finishing definitely degree, I was working as a clinical optometrist. I was doing, but that was not satisfactory, I was just doing contact lens and all. So I wanted to do something different. Then I came to know. So one day, me and one of my friend was discussing, कि यार ये मजा नहीं आ रहा है, रोज सुबह जाओ हॉस्पिटल रिफ्रैक्शन करो, contact lens करो, कई बार लो विजन कर लो, and वापस घर आ जाओ. मतलब somewhere it's not satisfying inner soul.
Correct.
So then he was like कि तो फिर तू ये कर लेना, तेरे को बीवी वैसे भी अच्छा लगता है, बीटी लाइक, so उसका फेलोशिप भी कर ले. So I was like really, but I don't know, maybe because of God's grace और उसी दिन क्लिक होना था or what, I don't know. But we just had a talk, and next day I just inquired in Dr. Shroff's hospital, Delhi. Said okay, like that was the end of April month, and they said okay, from May we are starting the new batch. Okay. So if you want to apply, you can apply. It's like, oh wow, that's great, so quick. So it was a quick decision, definitely, but it helped me. And then I went for a fellowship, and then after coming back, so 2011 I went. In 2012 we started in Shroff Vision Therapy Department. Then I'm seeing only BT patients.
Yeah.
Yeah.
That's actually correct. Once you taste the cream, then you won't like the cake at all. You just want the top cream and the cherry part.
Yeah, and this was like very much satisfying. And then I realized that this is my passion. I love to be with the children or the patient. This kind of problem I love to treat. So it's not like, I don't feel that I'm going in the morning, I'm coming back in the evening, and I'm just doing the same kind of work. Because anyways, I'm getting all different brains, all different patients. And it's always a challenging to treat. Okay, this patient, how I'll treat. So then I have to therapy.
Yeah.
So it's really like you get motivated basically.
Correct.
Okay, this is new, so now I can do this way. Okay, in this patient, because you don't have like in refraction how we go. Okay, minus essay, like there is no rule of here. There is no one therapy. Maybe one patient is showing good progress, but the other is not. So basically, for all patients, you have to customize your treatment plan.
Yeah, and every eye is different.
Yeah.
Even for the same patient, both eyes are different sometimes.
Yeah. So sometimes, one patient is very responsive in one particular treatment. Yeah. But in the same patient, if you do it with the other patient, he may not. So that way you need to work.
Yes.
And So many things. Recently, we have discovered, like I have finished the course in syntonics. I
Yes.
learned both the part like I have done with. So now we started with syntonics and we are seeing the change. So
Yeah.
it's always, something or the other new is coming in VT and you see the difference.
Yes, and like as you mentioned, you are working since 12 year in binocular vision department, like by BV specialist. So you might have seen the change. Like initially, people were doing the exercises, box doing, and those manual exercises. And now maybe I feel after COVID 2019, everything has shifted to software based. So I feel that
Yeah,
there was a
virtual.
transition from in-office vision therapy to home vision therapy, and you have been
Yes.
present in that phase. Like, so how was the transition for you? Like, was it easy or was it difficult to educate patient? Like, how was it?
So the thing is that, like, definitely initially it was difficult for
Yeah,
me to learn how to do this virtual things and
yeah,
all,
yeah,
but demand was virtual only. But
yeah.
then slowly, like, yeah, I attended many lectures from US where
Hmm.
they were teaching us how to do virtual vision therapy and all. So many big personalities from VT profession, they were on board and they were teaching and all. So I've attended many courses with them. And then I learned okay, how we can manage. But like still, I cannot rely completely on the virtual. Because
Hmm.
first of all, distance matters. Because
Yeah,
virtual, you're at the distance of 30 to 40 centimeter only. And your
it-
screen size is also
limited.
like,
13 inch,
uh,
15 inch. Yeah.
yeah. So it can improve at certain level, but then you have to treat the patient in open space.
Hmm.
Because end of the day, patient is dealing in the open space,
Yeah.
not with that closed environment,
Hmm.
right?
Correct.
So definitely initial stage with these both of then how I started incorporating virtual and the manual one, because manual is the like, for me,
Gold standard.
nothing
Yeah.
is best than manual. This
Yes.
is all very definitely all the softwares are, they are helping, but at certain level. Then you again need the manual one. So what I have started, I used to courier them the kit whichever required according to that condition.
Condition. Yeah.
We need to, and with this few leaflet that how you have to perform the test and everything. And through video call, we used to teach them how
Hmm.
manually you have to do, what all things you need to see, what all things if you are seeing that is correct. If you are seeing this way, that means it's wrong. So you have to change your posture or something like that. So we used to explain everything. And through the Zoom call, we used to monitor, and simultaneously we used to do it with the software also. So
Okay.
few things software has a good
Hmm.
result. We used to do those things with the software, and
Okay.
few things that's how we used to plan our session.
Passion. Okay.
So that way basically. So not only software based.
Hmm. Correct. So it's like software is a good to have system in a BB practice,
Yes,
while
definitely.
traditional BB exercises remains the gold standard. Correct? If I have understood
Yes,
properly. Yeah.
yes, definitely. Because software is, you cannot change the distance, because patient doesn't have a, for example, your mouse, you have to keep it in a, how many, like, keyboard is
Well,
like fixed there. Your mouse, few have wireless mouse, but you cannot go for till the distance of 6 meters or
hmm.
something,
Yeah.
correct?
The room
So
size.
when you, so
Yeah.
when you're treating the patient for a near target or smaller target, it's okay. So at certain distance, software is helping a lot. Definitely,
Yes.
yes. But when you are treating the patient for sports vision therapy or
Hmm.
for like first good stereopsis and all, like minute stereopsis are like 30 seconds of harm. So if
Yeah.
you are treating for that particular parameters way, then the software is difficult.
Yes. Okay. So as we talked about the transition from, traditional exercise to software-based vision therapy, I also feel that there is one more transition which is like more important and prominent. Like previously, what I feel is like people used to talk about convergence insufficiency, intermittent exotropia and all. But nowadays, people have started talking about neuro-optometry. CBI is one of the most important point. Then autism is like that. So is there a shift from from traditional BB practice to like more specialist neuro-optometry practice? Like, have you observed this pattern?
Yeah, definitely. It's a big jump. So first, I also used to treat normal binocular vision patients only,
Yes.
like all binocular vision anomalies, you can say, like CI, convergent insufficiency, AI, accommodative insufficiency, and we used to do traditional way like block string exercise, flipper exercise, pen
Yes.
push exercise, cat card exercise,
Yeah.
prism exercise, like that way.
Yes.
But upgrading myself with all the seniors like Dr. Mark Top, Dr. Robert Sanet, and
Hmm.
all, Dr. Glenn Steele, Cassandra.
Yeah.
So, like all these big personalities. So, after upgrading, and recently I said I have upgraded myself with the syntonics, like I've done the 2 courses on that.
Yeah.
And then we start seeing the patient and we like step into the neuro-optometry. And
Hmm.
that's why only I say that we are not treating the eyes, we are treating the brain.
Yes. Yes. Now it
So
makes
that is the
sense.
treatment is because of learning more and more into the neuro-optometry and seeing more and more patients from neuro-optometry field. I can say the statement that we are not dealing with the eyes, we are dealing with the
Yeah.
brains.
Yeah.
So yeah, definitely that is a big transition. So and after learning all from all these big personalities or big I can say seniors like from seniors, definitely I can apply this knowledge to my normal regular BB anomalies patient also,
Yeah.
and I treat this special population also.
Yes. Yes.
So yeah, that is a another one transition you can say from. So we say it's a VT, but VT is not only vision therapy for like
Yeah.
populations or for basically it involves the neurooptometry, it involves behavioral optometry, it
Hmm.
involves sports vision optometry, it
Yeah.
the psychology, it involves the light therapy, what we are doing, which occupational therapist also does sometimes.
Yes.
We also work with patients primitive reflexes also.
Hmm.
If you have heard about Moro reflex, which is very common like reflex. So
Yeah.
we with 5 reflexes. So
Hmm.
those reflexes developed in the mother's womb only, and we integrate those reflexes after coming out. Basically, baby
Yeah.
integrate those reflexes after coming out in the journey of 0 to 1 year.
Yeah.
Slowly.
Slowly.
If there is any reflex is not integrated, then patient may develop some or the other eye issue and body issue.
Hmm. Correct.
So we work on primitive reflex integrations also. So you can say like we do physiotherapy exercises also with our patients.
Yes.
So to integrate those reflexes, we have to do some physical exercises with the patient. Then
Correct.
we work simultaneously. We work with the balance of body also, because patients who have binocular anomalies, they
Hmm.
have balance issue, they have poor eye and hand coordinations, poor eye and body coordinations. So we
Hmm.
work on parameters also. So what few instruments which you see in physiotherapist department or you see in occupational therapist department, those instruments we also do have, like balance board, walking
Oh,
rail.
okay.
It's that way. So it's a like mixture of everything.
Correct. Correct.
It's not only like we are just dealing with binocular vision, we are dealing with the whole personality.
Personality. Yes. So,
So definitely you have to involve all different field of the vision therapy into one.
yes. So, like as you mentioned, modern binocular vision practice is not limited to optometrists. You may collab with the physiotherapist, a behavioral specialist,
Yes,
even a child psychologist, because it also plays an
yes.
important role in autism patient and that all patient. So it's a full of a collaborating practice. Yes.
Yeah, so basically for special populations, we do have a collaborations because
Yeah.
you can say like a holistic approach. They
Hmm.
require
Holistic.
vision therapy also. They
Yeah.
require therapy also. They require physiotherapy also, occupational therapy also, and some may require a counseling also, remedial justice also.
Yes.
So it's a full holistic approach.
Correct. Correct. Now I can understand more clearly like how we are dealing with this, with special population. And like, do you
Yes.
think that our current college academic knowledge is sufficient to deal with this thing, or like any student may require some additional skills, like say, let's say fellowship, anything else?
Yeah, definitely. Basically, in usual, like in academics, like
Hmm.
what curriculum you have in the college and all, that will introduce your normal BV,
BB,
normal vision, and how to treat normal binocular vision anomalies.
anomalies. Yeah.
Okay. Then to upgrade yourself, and
Hmm.
in college, you're learning only theory part. It's
Yes.
seeing
Yes.
cases and all during your internship and all. But
Yeah.
once you go to fellowship, definitely you upgrade yourself clinically,
Yes.
because you are seeing a bunch of patients, you
Hmm.
are seeing different conditions, you are dealing with your seniors in different conditions. So definitely you are gaining more from clinical fellowship.
Fellowship. Correct.
Yeah.
That is
So
a
that is my
yes. Yes. And like maybe we can conclude with that. Like let's say a student who is pursuing optometry right now, and like he has a dream to, start in BV practice or do a successful neuro-optometry practice. So what all tips you want to give to him or her? Like any conclusion tip to for students?
yeah. So the conclusion is on that only, like if you have an interest in
Yeah.
BV,
Yeah.
then you should go for it. This is a very fun-loving, enjoyable profession.
Yes.
And as I mentioned at the first only, it's very satisfactory
Yeah.
profession. Like you satisfied. Okay, whatever you did, it was worth it.
Worth it. Yes.
So if you are really uh, keen to learn more about this, then you should finish your graduation or masters, depending on whichever like course you are doing, graduation or masters. Then you
Hmm.
do the clinical optometry, like in pediatric optometry fellowship
Yeah.
or in vision therapy fellowship,
Yeah.
and you self, and then definitely you be with someone, you work with someone, and then you start your practice. So you
Correct.
will come to know what are the plus and minus
Hmm.
phases, and you are properly ready for it, and then you start your own practice. Because if you are for example, if you are finishing your fellowship or your education, like your bachelor or masters from XYZ city, and
Hmm.
then you are traveling to your hometown, and if you are starting immediately practice, then maybe half of the time people don't know you,
Hmm. Correct.
referrals will be difficult,
Yeah.
you know, word in mouth will be difficult. So in that case, maybe you work in your hometown for 1 or 2 years, you develop the networking, and then
Networking.
you start this.
Correct.
So that will help you bloom.
Network in terms of with doctors also and with patient also, because both are important to get more patient and
Yes.
yes, yes. Okay, okay. I feel that it was a great session with you. And with that, I just wanted to say a big thank you for taking all this time and sharing your experience with our viewers. So thank you, Priti ma'am.
Most welcome. Anytime.
Yeah, yeah,
Share the for me, like is a
yeah.
good honor for me also, like to uh, like give message to the juniors that how they can pursue further and all. So it's a great opportunity. Thank you so much for giving me this opportunity.
It was even my pleasure to have you and discuss more about binocular vision, and we really had covered almost all the points. So all thanks
Yeah.
to you. Okay.
And do let me know in case if any inquiries comes, or if any
Yeah.
student wants to go further in details,
Yeah.
then they can definitely contact me and I can
Yeah.
guide them.
In that case, maybe I can drop your email ID, which you have shared with me.
Yes,
I
yes,
can
you can
connect
do
with you
that.
via
Yes.
email only. Correct, ma'am?
Yeah.
Okay.